Physiologic issues are always the first thing we look at in patients. Age is not a reason, for instance, not to operate, but typically lung capacity is the rate-limiting step for a lot of patients. Most of these patients have some amount of emphysema. It varies from patient to patient. So we always test, and we would not leave them with less than a certain minimal lung capacity for good quality of life. And so that especially becomes an issue when you take out someone's lung, for instance, the whole lung. Those usually sort of push the limits of physiologic adaptation by the patient. As far as technical issues, there are many structures in the chest that the cancer can invade. And the question is which ones are resectable, which ones are not. And the other issues I will sort of present is when you decide to operate first before administering chemotherapy, which is the typical sort of instinct to give chemotherapy first, but sometimes that then does restrict what we can do surgically. And so there's a big sort of I guess there's some of a controversy as to whether chemotherapy makes someone more resectable, for instance. So you take a large tumor that initially looks like it would require a large operation and give them chemotherapy to allow for a lesser operation. Most of the data doesn't support that happens. So you have to decide up front, is the patient going to tolerate the large operation? If they tolerate it before you initiate therapy, they should be able to tolerate it afterwards. But if they don't before, from a physiologic standpoint, then don't expect it to happen afterwards.